Namaskar. You are watching Dr. KK Med Talks Fridays with Dr. Anita Khan, non-stop show, 1157th episode. Let's have the headlines of the day. India sees rise in pelvic inflammatory disease impacting fertility, leading to blocked fallopian tubes and higher chances of ectopic pregnancy. New evidence shows that women with previous C-sections have a higher chance of embryo implanting on the previous cesarean scar, requiring timely medical management. Gynecologists report an increase in ectopic pregnancies, urging women to get an early ultrasound between 5 to 6 weeks to detect abnormal implantation and prevent life-threatening complications. Health bodies now advise a minimum 18-month gap between pregnancies to reduce risk of ectopic pregnancy, preterm birth, and also maternal anemia. Clinicians say reliable period tracking apps help detect irregular cycles early, aiding diagnosis of PCOS, thyroid problems, and also early pregnancy complications. Now, let's go to the topic of the day. आज हम बात करेंगे एक्टोपिक प्रेगनेंसी, सेफ सर्जिकल मैनेजमेंट एंड रिकवरी। क्यों इतनी इंपॉर्टेंट है एक्टोपिक प्रेगनेंसी? आई लाइक टू टेल माय पेशेंट्स के एक्टोपिक प्रेगनेंसी इज लाइक अगर आपकी बॉडी में है तो यू आर सिटिंग ऑन अ टाइम बॉम्ब। हो सकता है बहुत कम पॉसिबिलिटी है कि ये अपने आप से रिजॉल्व हो जाए, वरना मोस्टली ये ग्रो करती है इन एन एबनॉर्मल प्लेस, नॉर्मल यूट्रस में ना होके या जगह में ना होके। जब ये ग्रो करती है, इसको स्थान नहीं मिलता, इसको ब्लड सप्लाई नहीं मिलती, तो एक दिन ये फट जाती है अगर इसकी ट्रीटमेंट ना हो, और तब वो कंडीशन जानलेवा हो सकती है। तो कैसे हमें इसे सेफ डायग्नोज कराना है और सेफली सर्जिकल या मेडिकल मैनेजमेंट करनी है, ये सब बताने के लिए आज हमारे पास स्पेशल गेस्ट हैं डॉक्टर मधुलता अलेक्जेंडर। Dr. Madhulata Alexander, she's an MD in Obs and Gynae, and she's a highly respected professor at Osmania Medical College, Hyderabad. With decades of clinical and academic experience, she's known for her expertise in high-risk pregnancies, reproductive health, and advanced gynecological care. Her work blends compassionate patient care with strong evidence-based practice. Dr. Madhulata has contributed extensively to teaching, mentoring, and improving maternal health outcomes, making her a recognized leader in the field. So, ma'am, today we will talk about ectopic pregnancy. So, shall we start?
Yes, sir. Yeah. Thank you, ma'am, for
So,
this introduction. Thank you.
not at all. What exactly is an ectopic pregnancy and how is it different from a normal pregnancy?
This is a very interesting topic. The word ectopic actually means abnormal place or position. Okay, it's about 6 to 3 per 1,000 births. And if you take pregnancy-related birth deaths in the first trimester, 4% of them are because of ectopic pregnancy. That is the importance of this condition. Now, what happens is we all know fertilization occurs in the fallopian tube. Okay, after fertilization, the developing embryo is pushed towards the uterine cavity by means of the salpinx. The salpinx will undergo spasmic contractions and the cilia beat towards the uterus. And developing embryo or the blastocyst will embed in the uterus, usually towards the fundus, anterior or posterior, by about 6th or 7th day. This is what usually normally happens. So a normal blastocyst develops, gets embedded by the 6th day. Now, for some reason, as Madam was saying, is there's a delay or whatever, will the at the 6th day the blastocyst will embed wherever it is. Okay, this is what it gets embedded and starts multiplying. That causes all the problems of ectopic pregnancy. Now, where all it can embed is it can either be in the uterus or out of the uterus. Now, the Carnoa is that part of the uterus which is near the fallopian tubes. When the uterus especially is not normally shaped, when you have a corneal pregnancy, or that blastocyst can embed into the cervix. It's called a cervical pregnancy. These are also ectopics. And as Bad was saying now, the cesarean scar pregnancy or pregnancy in the niche or isthmosele is increasing because of the increased incidence cesarean sections. That also forms a dangerous part of ectopic pregnancy. Ectopic pregnancies can also occur outside the tubes. In the fallopian tube, that is 97% of them occur in the fallopian tubes. It can also occur in the ovarian pregnancy, or even it can occur in the abdomen, that is abdominal pregnancy. It is different from the normal pregnancy because it does not develop in the uterus where it is supposed to develop. So therefore, we have catastrophic events, that is either it will rupture or blood vessel. We all know about the blood vessel. The supply of the blood to the uterus is both from the internal iliacs and also from the directly from the aorta, from the ovarian vessels. So if these vessels are involved, there will be torrential bleeding and the patient will be in shock. So that is why, because of the catastrophic events, that is why it's different from a normal pregnancy. Sometimes this pregnancy can just go undergo an abortion when it's the tube. It's called tubal abortion. This may be or may not be sympathetic. So that's how it is different from a normal pregnancy.
So, what are the signs and symptoms that a woman should watch out for when she misses her period to rule out ectopic pregnancy?
Yeah, ectopic pregnancy may have symptoms of early normal pregnancy, like it can have nausea, vomiting, etc. But main thing is how usually ectopic pregnancy presents is abdominal pain or pelvic pain with amenorrhea and some amount of vaginal bleeding. There may be some breast tenderness. Another cardinal symptom of ectopic is it has orthostatic hypotension. That is, when the patient sits up from the lying position, she has blackout. May have rectal pain when the fluid collects in the pouch of Douglas. All these may be symptoms of ectopic pregnancy. But sometimes the patient may be absolutely asymptomatic. She may not even have had missed a period. That also could be ectopic. So whenever a pregnant woman comes to your OPD in the first trimester, ruling out with any complaint, ruling out ectopic should be your priority in every case. In fact, when any patient comes into our OP, we also go on checking the pregnancy test, because if the test is positive, at least it allows you this problem is pregnancy related. Where is the pregnancy? So even in our, where I work in a government hospital, so we do not miss this problem. Okay.
Yes. Now, what I want to know, another thing that I want to know from you is that can it be detected without any symptoms during a first visit?
Yes, it can be detected because nowadays transvaginal ultrasound has undergone, everybody knows how to do it. We are all very
Yes.
confident of doing it, and this can diagnose symptoms 1 week before the abdominal scan. So most of us gynecologists are doing TVS, transabdominal scans. Whenever a patient comes, we confirm the pregnancy, confirm the location of the pregnancy. Okay, so it can be detected usually by a transvaginal scan. Not this, we combine all the symptoms, we check the period, we check her history, because a previous ectopic pregnancy has a chance of recurrence. Then we also see for pelvic and abdominal tenderness. Then other thing is cervical rocking movements also. If there's pain on cervical rocking movements, we document it, and again we look for pregnancy. Sometimes if the ectopic has ruptured, there'll be free fluid in the abdomen. There will be peritoneal signs. There'll be rebound tenderness. There may be a distension. And extreme cases, we have the tachycardia and the BP. And of course, as I mentioned, the orthostatic hypotension. But main thing is, with the clinical symptoms, we can diagnose. Earlier days, when I first started my practice, we used to do something called culdocentesis. But I think now it's a thing of the
Yes.
past because of the excellent
Mhm.
transvaginal ultrasound, which can detect. Immediately, we are able to say this is hemoperitoneum, this is an ectopic. And then many of the times, even in emergencies, we are able to diagnose the exact location of the
Ectopic. Right. Who is at a higher risk of having an ectopic pregnancy?
Probably the highest risk is a patient who had a previous history of ectopic. About 10% of these patients had a history of ectopic or any condition where there is PID, pelvic inflammatory disease. This, especially tuberculosis, chlamydia, these specifically attack the tubes. This also can cause ectopic. Anytime the tubes are involved, the tubal surgery, like when you recanalize them, or when you have, even it's known to have occur after tubectomy. Okay, IUDs, intrauterine devices per se do not cause ectopics, but if you take the pregnancies who occur in patients who have IUDs, these patients are having more chances of having ectopic. Another condition where patients can have ectopic is when they're treated for prolonged infertility or they have multiple sexual partners. Also, ART procedures also cause ectopic pregnancies. Surprisingly, these ectopics occur mainly in the ischemic regions, whereas other ectopics occur in the tube. Okay, but the most surprising part is the majority of patients who have ectopics do not have any risk factors. So just because you do not have, you cannot think that you do not have ectopic. Most of the patients who have ectopic pregnancy do not have any risk factors.
Right. Uh, Besides the ultrasound, before the ultrasound can pick up a pregnancy, is there any other test to confirm an ectopic pregnancy?
Yes, we have the excellent beta HCG. Okay, it's the same thing what we detect the urine for the urine pregnancy test. The same thing will detect the blood called beta HCG. Now, in a normal pregnancy, the beta HCG doubles about every 48 hours. Okay, this beta HCG, it's not doubling at the same time, it's only increasing less than 35%. Or if the levels of beta HCG are plateauing or decreasing, this alerts you this pregnancy is not normal. Where is it? Is it the pregnancy? Is it an abortion? Or is it a pregnancy that's not implanted in the right place like an ectopic? Beta HCG is a wonderful tool to diagnose ectopic pregnancy. It alerts you. And also there's something else, pregnancy of unknown or relocation, that's PUL.
Yes.
Here also there are three possibilities. One, it could just be a pregnancy that is normal, it's taking some time to show up in the uterus. The uterus is empty, maybe it will show up after some time. Another thing is the pregnancy could be ectopic, or it may be a pregnancy which could be lost like an abortion. Usually in these conditions, the pregnancy will be less than, the beta HCG will be less than 200 international units per ml. Now, there is some level in which you should be able to see a intrauterine pregnancy. That's around 1500 international units per ml. If the beta HCG, you should be with reasonable clarity. You should be able to say, yes, pregnancy is intrauterine. If you are not able to see, rethink, go through your diagnosis again. And by 2000, yes, definitely you should be able to see the yolk sac. You should definitely be able to see the gestational sac. Plus, either yolk sac or the embryo. If you're not able to see, rethink, re-diagnose, take help from other seniors.
How dangerous can an untreated ectopic pregnancy become?
See, as I told you, the poor blastocyst, the poor embryo doesn't know what's happening. He's sitting in one place that's not supposed to be sitting. It goes on multiplying. At one point, it's going to rupture. And as I told you, if a major blood vessel is going to get in, the patient present in shock. Okay, at some point it's going to be. Sometimes they just undergo simple abortion. Sometimes we have diagnosed patients incidentally long, and they'll be having something called a chronic ectopic where it all gets organized into a blood clot. So usually, and this will affect your future fertility, affect so many things. So that's why you must treat an ectopic pregnancy in whatever way you want.
So, talking about whatever way, is surgery always required, or some other medical treatment, some drug can take care of uh, ectopic pregnancy in some cases?
Yes, we have methotrexate. It is a wonder drug. What is it? It's an anti-metabolite. It prevents division of actively dividing cells. It inhibits the enzyme DHFR, dihydrofolate reductase. Okay, it acts on cells which are actively dividing, like the embryo, bone marrow, or the buccal mucosa, or whatever. One thing is, if you use it, act also on the multiplying embryo cells, and it has shown excellent results. But main thing is it cannot be used in all patients. Certain indications where you can use methotrexate. The patient first thing should be hemodynamically stable. Only then you can think of a medical treatment. Beta HCG should preferably less than 1500, but up to 5000 you can use. If the beta HCG levels are very high, you know you're going to get you're not going to get benefit by using the methotrexate. The patient should not be having a concurrent intrauterine pregnancy also. That's called a ectopic pregnancy. The patient, one more thing is when using methotrexate, the patient, there should not be cardiac activity. And also, the patient is willing for medical treatment. Many times when we tell them, give the options, patients say, no, madam, I don't want medical treatment. I only want to go for surgery. Okay. Sometimes there are some contraindications for methotrexate, like if they're sensitive to methotrexate, if they have liver problems, renal problems, and sometimes they have, you cannot use it at all. So these patients also, we do not give methotrexate.
Yes, many a times patients will say, this is a chance. I have completed my family. Take out both the tubes. So that is also an
Yeah, if
indication.
yes, it's good. If the patient wants, as madam was saying, if
Yes.
the patient wants to have concurrent tubectomy, she doesn't want this pregnancy, she's complete her family, then you can go ahead for surgery. Okay. So other things, other indications also there when we prefer surgery to medical treatment. But it all depends on each patient and how what they want in life.
Yes. So there are various ways of operating for ectopic laparoscopy and open surgery. So what is the difference between these two types of surgeries for ectopic?
Yeah, the two kind of surgeries that you said, madam, is laparotomy, where you open the abdomen, big incision. You open the abdomen, cut through all the layers, and you reach the uterus. Or you have the laparoscopy, where you do the keyhole surgery, which is few incisions, small incisions are made, and you operate from outside. Okay, but now what it happens is you have to, or what decision are you going to make? Main thing is your expertise. Are you capable of doing a laparoscopic surgery? How competent is the doctor? Now, in many places, it is available round the clock. But see, I work in a government place where there would be one OT running and continuously the OT will be running. We cannot usually do ectopics as an emergency through laparoscopy because we cannot block the OT for this case. We have to work fast. Okay. But daytime, we have many theaters we can easily do laparoscopy. Another thing is laparoscopy is you need the laparoscopic, the skills of the doctor. You must have a lap surgeon. You must have the lap equipment, general anesthetist, anesthetist must be competent enough to give surgery. All these factors will give you indication whether the patient is going to have lap or laparotomy. But easier is if you are in doubt, go ahead. If the patient is hemodynamically unstable, you are not confident, go ahead and open the abdomen and do it. Okay. So another
You've
thing is why
already.
you'll go ahead for
Mhm.
yes, ma'am.
Yes,
Why
yes.
you'll go ahead for surgery is supposing you want to do a surgery. Now, either lap or laparotomy. Supposing you want to do a tubectomy. If you are confident enough, go ahead by doing the laparoscopy and they do tubectomy, remove the tube. But sometimes what happens is this patient you know is a bad case, chronic infertility. She is definitely going to go for IVF. She has hydrocephalus. Then you'll also be doing surgery for this case. You won't be giving her the option of medical treatment. So in this patient, either you do laparotomy or you do laparoscopy, depends on the operating surgeon.
So
Another thing
you've told
is
me.
if you
Hmm.
yes,
Yes,
ma'am.
yes,
If you
ma'am.
want to do laparotomy, I mean, if you want to do, there are two kinds of surgery you can do on the tube. You can either
Hmm.
remove the tube totally, that's called salpingectomy, or you can
Hmm.
do salpingotomy. That is, you open the tube, you nip it, and you remove the contents. For some time, or a few years back, we were doing salpingotomy before. But if the content at the other tube is healthy, if there's no surgeries on the other tube, go ahead and remove this tube, salpingectomy. But if the other tube is not so good, probably you may go in for a salpingotomy. You open the tube. But other thing when you have to convince the patient is if you're doing a salpingotomy, you may be leaving some tissue behind, it may start, which may also multiply. So this patient may need methotrexate, will need follow-up, may need surgery later. So all these you should counsel the patient before doing the treatment.
How soon can patient expect to recover after laparoscopic surgery?
Yeah, if the patient is going to undergo laparoscopic surgery for ectopic pregnancy, they will recover perfectly within 2 weeks. Okay, they are able to lead a normal life after 2 weeks. But we tell the patient, do not conceive at least for 2 menstrual cycles. So at least you give a 3 month gap. Even if you have methotrexate, you have to give a 90-day period before patient can think of conceiving. You must counsel the patient before the patient goes home about when she can plan her next baby. They may recover well after laparoscopic surgery, but patients should be given advice. You should not do strenuous exercises. You should not be having sex. All these things should be informed to the patient in writing before she goes home.
And what emotional or psychological impact can an ectopic pregnancy have on a female or her family partner, for that matter?
This is going to have a big psychological impact. In fact, all our patients are very tech savvy. They all know about ectopic and they know their chances are one tube is gone, one tube is ruined. They all know about it and they have so many questions to ask us. So we should give them support. We should give them psychological support in them and their partner. We should be sympathetic to them. We should clear all their doubts and we should take time. Maybe one session will not hold good. We should take time. We should ask them how to plan the next pregnancy. We should reassure them. We should give them figures. How many people have conceived after ectopic? We know many people have conceived, but we should always give the correct facts and figures to the patient, and they need emotional support definitely.
No,
Also, we
will
should tell
having
them,
an
yes, ma'am.
yes, yes, ma'am.
Yeah. Also, which pain management you should also tell them. They will have pain after
Yes.
surgery. Okay, you can give them paracetamol. Be careful. Don't give them ibuprofen or SAIDs, especially if you give them methotrexate. And also, when they go home, they have bleeding, isn't it? Tell them
Yes.
no tampons. You should not be putting in something because they cause infection. Also, we should give them uh, advice about the wound care after ectopic pregnancy.
So, will having an ectopic pregnancy affect their future fertility?
Yes, it will. Because if you have ectopic means one tube is gone, depends on what you have done to that tube. It will have an effect on the future fertility. 10% of them have a recurrence of ectopic also. So that's also a problem. So we should tell the patients their options and maybe we should follow them up and give them the options of ART. ART cycles also have an increased chance of ectopics. All this should be counseled to the patient before they leave.
And what steps can be taken to reduce the risk of a future ectopic pregnancy?
Yeah, first thing is tell the patient as soon as she misses a period, she has to go and meet a doctor. Early pregnancy, she must see a doctor as soon as she misses a period. Early ultrasound, LDL beta HCG should be done. And in case she had any pelvic infection, treat immediately. Tell her all about safe sex, what all she can have. And also another important thing is avoid smoking. You will be surprised how many of our patients are smoking because this affects tubal motility. And if the motility decreases, the blastocyst will embed before. And also if the tube has a hydrosalpinx or some additions, maybe you have to do surgery before the patient thinks of getting pregnant.
Is there any role of some follow-up care, like, and test like HSG before she goes for the next pregnancy?
See, HSC generally we don't advise routine nowadays, but unless there's an indication, because definitely one tube will be blocked. And if the patient is going to see it, she's going to go for a six. So usually, generally, we don't do HSG before, after she has the pregnancy. But sometimes what happens is patients are anxious and we may be going in for IVF. So in these conditions, we do a laparoscopy and we see if any additions are there, whether how the tubes are, and then we can give the patient a picture about how she can conceive and when.
Right. So, can women use contraception immediately after recovery, and what types are safe?
Yes, patients should be given contraceptive advice immediately after the surgery. And also, don't forget to give anti-D. If the patient is Rh negative, we have to give anti-D.
Yes.
Barrier contraception is recommended. Also, you can give combined contraceptive pills or even progesterone only pills. Injectable contraceptions are a good advice. When the patient is going, you can give her the DMPA. Implants are becoming very popular nowadays. And
Yes.
I will actually, when recently when I went to Chennai as an examiner, those patients are really accepting implants. I was very surprised that Indian patients could be accepting, but they are so readily
Mhm.
accepting implants. So this is a very good option after ectopic. That if the patient asks for IUD, yes, you can tell them about IUD. But if a patient conceives after IUD, the more chances of it being ectopic. But IUD per se, intrauterine device per se, will not cause ectopic.
Okay. So, what message would you like to give to a woman to help them seek timely care and prevent complications?
Main thing is early diagnosis, report to your doctor early, practice safe sex, treat any pelvic infection immediately. Okay. And also, you have various options. You should know about it: laparoscopy, laparotomy, and also medical treatment. And main thing is follow up. You should go back to your doctor, ask when it is safe to conceive, and any psychological support will be given to you.
Right. So that was very knowledgeable information you have given to our viewers and listeners. So thank you, Dr. Badulata Alexander, for joining us today. Could you show us the certificate, please? That is a small token of thanks from our side.
So, no.
You took out time and talked so well about such a complex matter. Thank you so much. That will be all
Thank
for
you, madam.
today. Welcome, ma'am. Dr. KK Med
Thank
Talks
you.
will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks. Namaskar.
Thank you. Good evening.